Usually when we talk about a medical diagnosis, there's this expectation of pure precision.
Oh, yeah, very binary.
Right. It feels almost like engineering.
Yeah.
Like you break your arm, the x-ray shows that jagged white line, and the doctor just points at the film and says, well, there it is. That's the problem.
Broken or not broken, you can just point right to it.
But then you step into the world of physical care, specifically the daily realities of mobility and transferring another human being, and suddenly that x-ray machine is broken.
It is completely useless.
Yeah. We are no longer looking at clean, static images. We are looking at this incredibly murky landscape of physics, human unpredictability, and safety protocols.
It really is diagnostic muddy waters,
Yeah.
because you aren't dealing with a static object. You are dealing with a dynamic, breathing, moving, and sometimes highly unpredictable person.
And their center of gravity can change in a fraction of a second.
Exactly.
And that unpredictability is exactly what we are tackling today. Welcome back to the Cert Prep Academy CNA Exam Prep podcast and to another deep dive.
Glad to be back.
For those of you who have been with us since the beginning, welcome back from episode 1. As a quick reminder, this is an 11-episode series covering all 6 NNAAP written exam topics.
That's right.
Each deep dive stands entirely on its own, so you can jump around to whatever topic you need to focus on. But if you're following the whole journey, it is great to have you here. Today we are focusing on episode 2. Physical Care Part 2, Positioning, Mobility, and Transfers.
Our mission today is massive. We are extracting the absolute core concepts from the NNAAP handbook and the exam practice questions.
We really need to figure out the crucial mechanics of moving residents.
Right, and just as importantly, moving yourself safely. This isn't just a small section of your test. Basic nursing skills make up 39% of the exam, and restorative skills make up another 8%.
Oh, wow. So that means almost half of your entire test is tied up in the concepts we're about to unpack.
It's a huge chunk.
I was actually looking through the Cert Prep Academy practice test last night, and mobility scenarios are literally everywhere. They are baked into almost every single clinical situation.
They really are.
So if you are listening to this right now, locking these concepts down is going to score you major points on exam day.
You really can't be a functioning CNA without mastering this. It is the foundation of everything. I mean, you simply cannot provide effective care if you can't safely move a resident.
Or worse, if you injure your own body in the process.
Exactly.
Okay, let's unpack this, because before we can safely move a resident, we have to talk about how the CNA moves their own body. It's like the airplane oxygen mask rule.
Yes. Secure your own mask first.
Right. You have to secure your own safety before assisting anyone else. You can't provide care if you throw out your lower back on a Tuesday morning because you reached for someone the wrong way.
The foundation of all physical care starts with your own body mechanics, and the exam tests this rigorously, mostly because back injuries are one of the leading causes of career-ending injuries for nursing assistants.
That is so scary.
Yeah.
Let's put the listener in a scenario. Imagine you have a resident with limited mobility who needs assistance with dressing. They're sitting on the edge of the bed, maybe leaning a bit forward, and you need to help them stand or adjust their clothing. What is the absolute rule for your posture in that exact moment?
The absolute rule, and this is the correct action they're looking for on the exam, is bending at the knees and keeping your back straight while assisting.
I feel like we hear lift with your legs all the time, but in the heat of the moment, people instinctively do the exact opposite.
They lean over from the waist.
Right. Why is that?
Well, it comes down to a misunderstanding of human biomechanics. Let's look at why bending at the waist is such a disaster. The human spine is a remarkable structure.
It really is.
It is highly articulated, flexible, and houses the central nervous system. But, it is not a crane.
Not a crane. That's a good way to put it.
It is designed for vertical stability and flexibility, not for acting as a lever to hoist heavy loads from a bent position.
So when you bend at the waist and try to lift, what is actually happening inside the back?
You are putting immense asymmetrical pressure on your intervertebral discs. These are the little jelly-filled shock absorbers between your spinal bones.
Ouch.
When you bend forward at the waist and pull weight up, you are compressing the front of those discs and squeezing the jelly backward toward your spinal cord.
Oh man, that makes my back hurt just thinking about it.
That is exactly how you rupture or herniate a disc. You are using the small, easily strained muscles of your lower back to do the job of a forklift.
I always compare this to deadlifting at the gym. Like if you walk up to a heavy barbell and you lock your knees completely straight,
Oh, terrible idea.
right, and you just heave it up using only your lower back, you are going to snap in half. Everyone knows that.
Yeah.
So why would you do that when assisting a human being?
Especially a human being who might suddenly shift their weight or lose their balance.
Exactly.
That analogy is perfect. When you bend at the knees and keep your back straight, you are keeping your center of gravity low.
Which is key.
More importantly, you are shifting the workload away from the fragile spine and onto your quadriceps and glutes. Those are the largest, thickest, strongest muscle groups in your entire body.
They are biologically engineered for heavy lifting.
Precisely. So the test wants to make sure you are relying on the heavy machinery, your legs, and not the delicate machinery of your spine.
What about lifting with the arms? I've seen people try to just muscle a resident up by pulling with their biceps.
Which is another classic wrong answer on the exam. Lifting a human being with just your arms is a fast track to a torn bicep or a severe rotator cuff injury.
Yikes.
The arms are meant to guide and stabilize, not bear the entire brunt of a 150-pound load. You always bring the workload close to your center of gravity, engage your core, and let your legs do the pushing.
Okay, so that makes perfect sense for a planned movement. You have time to set your feet, bend your knees, and brace your core.
Right.
But what happens when safety mechanics are tested in real time, like a sudden zero-warning crisis?
Those are the moments where reflexes battle against clinical protocols.
Let's do a scenario. Imagine this. You are assisting a resident with a shower. The environment is loud, the water is warm, the floor is wet.
A very common high-risk situation.
Suddenly, the resident becomes dizzy. Their eyes roll back a little and they grab your arm for balance. They're going down.
This is a terrifying moment for any healthcare worker. Your natural human instinct, your reflex, is to catch them and try to heave them back up into a standing position.
Because you want to fight gravity.
Yes, you want to fix the problem immediately.
But the protocol says the complete opposite, right? The correct action is to help the resident sit down immediately, wherever they are, and then notify the nurse.
Let's break down why fighting gravity is the wrong move here and why the exam tests this specific scenario. First, let's look at the physiology of what's happening to the resident. Why did they get dizzy in the shower in the first place?
Is it the heat?
Yes, exactly. A hot shower causes vasodilation. The warm water makes the blood vessels in the skin expand to release heat and regulate body temperature. When those blood vessels dilate, the blood pools in the extremities, which means blood pressure drops. Suddenly, the brain isn't getting enough oxygen-rich blood.
And boom, they experience sudden dizziness or syncope, which is fainting.
Right, so their body is literally losing consciousness and structural integrity.
If you try to hold them up, you aren't just supporting their weight. You are fighting dead weight on a slippery surface.
If you try to wrestle them back to a standing position, two things will happen. One, you will likely destroy your own back because you are in an awkward, compromised position.
Yeah, and two,
And two, you are going to fail. They are going to slip. And because you're holding on to them, they are going to pull you down with them onto a hard, wet tile floor.
and if we look at some of the wrong instincts people have here, one option people often think is right is to tell the resident to lie down flat in the shower so they don't fall.
Which is incredibly dangerous. A shower floor is hard, confined, and actively filling with running water.
Right, it's basically raining.
If you try to ease someone all the way down to lie flat on their back in a running shower, you introduce a massive risk of head trauma if they slip during that long descent.
Even worse, if they are lying flat with water raining down on them, you introduce the immediate risk of them aspirating or inhaling water.
Exactly. What about stopping the shower and walking them out to the bedroom to lie down? That sounds reasonable, right? Get them out of the wet environment.
It sounds reasonable until you analyze the immediate physics. If someone is actively dizzy, swaying, and grabbing you for balance, trying to walk them 10 or 15 feet across a wet bathroom floor and down a hallway is practically guaranteeing a catastrophic fall.
You are ignoring the immediate, acute danger.
So by helping them sit down immediately, whether that's guiding them onto a shower chair that's already in the stall, or even carefully easing them to a seated position on the floor if no chair is available, you are instantly lowering their center of gravity.
That is the key phrase, lowering the center of gravity. You eliminate the distance they can fall.
That makes a lot of sense.
If they are already sitting on the floor or a low stool, they can't fall and hit their head. You have neutralized the immediate physical danger.
And once they are safely seated and that acute fall risk is managed, then you hit the call light, or notify the nurse.
Because sudden dizziness is a clinical symptom that requires medical assessment.
Safety first, stabilize the environment, then get the medical assessment. I love the logic behind that. It really moves you away from panic and toward clinical reasoning.
It really does.
So we've got the CNA's body mechanics dialed in, and we know how to handle a sudden center of gravity crisis.
The next logical step is learning how to manipulate a resident's position in a controlled environment, which brings us to the bed.
Which honestly seems like it should be the easiest part, right?
Yeah.
Like they're already lying down, but the guidelines for this are incredibly strict.
Because proper positioning in bed isn't just about fluffing pillows and making someone comfortable. It is a vital medical intervention.
How so?
When a person is immobile, their own body weight compresses the blood vessels between their bones and the mattress. If they aren't repositioned properly and regularly, that tissue is starved of oxygen and dies.
And that causes life-threatening pressure ulcers.
Yes. Furthermore, proper positioning is necessary for completing almost all activities of daily living.
I know the NNAAP exam gets highly specific about the exact sequences for this. Let's talk about the specific skill of turning a resident onto their side.
Skill 17 in the handbook positions on side. The steps for rolling a resident are meticulously ordered, and skipping one can mean failing the skill.
Okay, where do we start?
You always start with hand hygiene, explaining the procedure to the resident, even if they are unconscious, and providing privacy.
Okay, so the curtain is pulled, hands are washed. What is the very first physical thing you do to the bed before you even touch the resident?
You lower the head of the bed until it is flat.
I always wondered about this. If someone is sitting up slightly, say at a 30-degree angle, why can't I just grab their hip and shoulder and roll them over? Why take the time to lower the bed completely flat?
Well, imagine trying to push a heavy box horizontally across a ramp that is sloping upwards. You are fighting gravity, right?
Oh, definitely.
When the head of the bed is elevated, rolling a resident requires you to push their upper body weight up an incline. But it's worse than just being heavy. It creates immense friction and shearing forces on their skin.
Wait, let's define shearing force, because that comes up a lot.
Yeah.
How is that different from just rubbing the skin?
Friction is two surfaces rubbing together, like the skin dragging against the sheet. Shearing is deeper and more destructive.
Okay, visualize it for me.
Imagine the skin is stuck to the bed sheet, but the underlying bone and muscle keep moving. The layers of tissue are literally pulled in opposite directions.
Ouch.
This stretches and tears the tiny blood vessels, the capillaries, under the skin. It causes deep tissue injury before you even see a mark on the surface.
So lowering the bed to a flat, neutral surface eliminates that incline, reducing the effort you have to exert and protecting the resident's tissue from those shearing forces.
Exactly.
That makes so much sense. Flat bed equals neutral gravity. So the bed is flat. I'm standing on the right side of the bed. I want to roll the resident away from me onto their left side. What's the next step?
Before you roll them, you must raise the side rail on the side the body will be turned toward. So you walk over to the left side, raise that rail, and then walk back to the right side.
I feel like a lot of people would skip this to save time. But the logic is pretty clear once you visualize it. If I'm rolling them away from me and there's no rail on the other side.
You might push them right off the edge of the mattress onto the floor. It happens.
Terrifying.
Raising that rail provides a critical physical barrier. It also provides immense psychological comfort for the resident. Being rolled blindly away from your caregiver toward an open drop-off is terrifying.
That rail makes them feel secure.
Then you assist the client to slowly roll onto their side toward that raised rail.
Okay, they are rolled over. Now comes the pillow placement. This is a huge area for mistakes. There are 4 specific supportive devices, usually pillows or wedges, that need to be placed.
Yes, 4.
When you are nervous and the examiner is watching with a clipboard, it's easy to forget one.
How do you remember the sequence?
I have to use a mental checklist. I think of it top to bottom, like head, back, arm, legs.
That is a perfect logical progression. Let's walk through it.
First, I place or adjust the pillow under their head. If they just rolled, their head is probably awkwardly twisted. The pillow supports the cervical spine, so their neck is aligned with their back.
Correct. Second, you place a supportive device tucked firmly behind the client's back.
This acts like a wedge, right? So they don't just slowly flop backward onto their spine once I let go of them.
Exactly. It maintains that lateral side-lying position. Third, you support the top arm with a device.
Now, why does the top arm need a pillow? If I'm lying on my side, my top arm just rests on my side.
But think about the weight of that arm over a couple of hours. Without support, the heavy top arm drags down across the chest.
Oh, I see.
This pulls the shoulder joint forward, constricting the chest cavity and making it harder to breathe, while also putting strain on the shoulder capsule. A pillow under that top arm keeps the shoulder in a neutral, open position.
That makes total sense. Head, back, arm. And fourth, the legs. I place a device between the legs, but the handbook specifically notes there's a very strict rule for how this fourth pillow is placed.
The rule is that the top knee must be flexed, meaning bent, and both the knee and the ankle must be supported by the pillow.
What happens if I just stick a pillow between their knees, but their top ankle is hanging off the edge of the pillow?
You have just created a pressure point. The weight of the top leg will cause that unsupported ankle to angle downward, grinding the top ankle bone directly into the bottom ankle bone.
Bone on bone. The friction and the pressure. Ouch.
It's incredibly painful and a prime spot for a skin tear or ulcer. The pillow must extend all the way down to support both the knee and the ankle, keeping the leg entirely parallel to the bed.
So, head, back, arm, legs. But there is a crucial hidden step tucked into the middle of Skill 17 that examiners are notorious for failing people on.
Oh, yes.
After they are rolled over, but before you walk away, what do you have to do to the bottom arm?
You must reposition the arm and shoulder so that the client is not lying directly on top of their own arm. You have to physically pull that bottom shoulder slightly forward.
I try to relate this to my own life.
Yeah.
Have you ever fallen asleep in a weird position on the couch, lying on your arm, and you wake up and it's completely dead?
Like heavy tingling and you can't move it. We've all done it.
Right.
That tingling is ischemia. You are compressing the nerves and cutting off the arterial blood flow to the limb. Now, if that happens to you, you wake up, realize it hurts, and shift your weight.
But what if you are a resident who is paralyzed on that side? Or what if you have advanced dementia and cannot communicate that you are in pain?
You would just lie there crushing your own arm for 2 hours until the next turning schedule.
That's awful.
And that can cause permanent, irreversible nerve damage and severe tissue necrosis. You must pull that bottom shoulder slightly forward so their weight is resting on the flat blade of the scapula on their back rather than directly on the fragile shoulder joint and the blood vessels of the arm.
See, these aren't just arbitrary rules to make the test hard. Every single step is a defense mechanism against a catastrophic injury.
That is the exact mindset you need for the exam.
So that's a standard side-lying position for pressure relief. But the exam also loves to test task-specific positioning, meaning which position is required for a specific medical or hygiene task.
Let's explore that. In the practice materials, there's a scenario asking about the most appropriate position for a resident who is receiving a shampoo in bed.
When I first thought about this, I thought, well, they're getting their hair washed in bed, so they should lie flat on their back, like at a salon sink. But that's wrong.
The correct answer is the semi-Fowler's position, with the head extended slightly over a shampoo board or basin.
If you are studying for this exam, you absolutely have to understand Fowler's positions. What actually is semi-Fowler's?
Semi-Fowler's means the resident is on their back, but the head of the bed is elevated, typically on an incline of around 30 to 45 degrees. It's a gentle, reclining, upright angle.
So why is a 45-degree angle better than lying totally flat for a shampoo?
Think about the mechanics of the water. If the resident is lying completely flat, supine, where does the water go when you pour it over their scalp?
It has no direction.
Exactly. It will pool around the back of their neck, soak into their gown, run into their ears, and saturate the mattress. It's a mess.
But if they are in semi-Fowler's at that 30 to 45-degree angle with their head tilted slightly back over the edge of the basin,
Gravity does the heavy lifting. The incline forces the water to drain efficiently backward, away from their face and ears, directly down the trough of the shampoo board and into the basin.
what if we sit them straight up, like a 90-degree angle, high Fowler's position?
If they are sitting at 90 degrees, high Fowler's, and you try to wash their hair, their neck has to flex forward. The water's going to pour right over their forehead, down their face, and into their eyes and nose.
Which would be terrifying for the resident. They would be sputtering and choking. It's an aspiration risk just from bath water.
Precisely. So semi-Fowler's hits the perfect middle ground. It uses gravity to direct the water harmlessly away from the airways and into the basin.
I actually got a similar question wrong the first time I went through the Cert Prep Academy question bank, so that semi-Fowler's rule really stuck with me,
Yeah.
because it applies to the bedpan too.
Yes, there is a classic question about the most appropriate position for an immobile resident requiring a bedpan. The correct protocol is, again, semi-Fowler's position with the bedpan placed under the resident.
Now, mechanically, Placing a bedpan under someone who is lying completely flat on their back seems infinitely easier. You just roll them slightly, slide it under, and roll them back. Why go through the trouble of elevating the head of the bed to 45 degrees?
Because human biology and the physics of elimination do not cooperate with a flat supine position, think about how the colon and rectum are situated.
Yeah.
When you sit upright on a normal toilet, gravity assists the descending colon. More importantly, sitting upright allows the abdominal muscles to engage and create intra-abdominal pressure, which is necessary to bear down and eliminate waste.
If you are lying completely flat on your back, your abdominal wall is stretched out. You have zero leverage to push.
None. Lying flat makes it incredibly difficult, frustrating, and physically exhausting for the resident to have a bowel movement.
It just fights their anatomy.
By elevating the head of the bed to semi-Fowlers, you are mimicking a natural seated posture as much as possible within the confines of the bed. You utilize gravity, you allow the core muscles to engage, and from a purely psychological standpoint, sitting up provides a much greater sense of dignity during a vulnerable moment than lying flat on your back.
And if we analyze the wrong answers they throw at you for that question frame, meaning face down on their stomach, is physically absurd for a bedpan. You couldn't even place it.
Right.
And side lying only on the left side might be okay for an enema, but it's incredibly restrictive and inefficient for using a standard bedpan for a regular bowel movement.
That brings up another critical use of upright positioning, and it involves feeding.
Right. There's a scenario where you are feeding a resident who has a documented difficulty swallowing. Dysphagia. What is the safest position for them?
The absolute safest position is sitting fully upright or semi-upright at a 45 to 90 degree angle.
So we are talking high Fowlers, or at the very least, a steep semi-Fowlers.
Yes, and the reason for this goes back to the severe risk of aspiration.
Which is?
Aspiration is when food, liquid, or saliva enters the airway, the trachea, and goes into the lungs, instead of going down the esophagus into the stomach.
Why does the angle of the bed prevent that?
Let's look at the anatomy of the throat. When you swallow, a little flap of cartilage called the epiglottis folds down to cover your windpipe, acting like a trapdoor so food slides past it into the stomach tube.
Makes sense.
When you are sitting upright, gravity pulls the food straight down, and that trapdoor can easily swing shut.
But if you feed someone who is lying flat,
Gravity is no longer pulling the food down past the trapdoor. The food pools in the back of the throat. It sloshes around the airway.
yikes.
The epiglottis has to fight against the angle to close properly. The chances of a liquid slipping past it and into the lungs skyrocket. And if food or liquid gets into the lungs, it introduces bacteria, causing aspiration pneumonia.
Which is incredibly dangerous, especially for an elderly or frail resident. It can easily be fatal.
It is a leading cause of preventable death in these facilities. That is why positioning is never just about comfort. It is a clinical shield. You are using the mechanical angle of the bed to utilize gravity. You use gravity to wash hair cleanly, to eliminate waste efficiently, and to safely guide food into the stomach instead of the lungs.
Okay, that is a massive takeaway. Gravity is either your best friend or your worst enemy, depending on how you set the bed. So we've got them safely positioned in bed, but positioning is static. You are just holding them in a safe pose. Mobility is dynamic. Even if a resident is completely confined to bed, their body must keep moving. This brings us to range of motion, or ROM.
Range of motion is crucial because the human body is designed for movement. If a joint isn't moved regularly, the muscles, ligaments, and tendons around it will begin to shorten, tighten, and atrophy.
This leads to contractures, right? I've seen photos of this in textbooks, and it looks horrific.
It is. A contracture is when the joint becomes permanently frozen in a bent or flexed position. The fingers might curl tightly into the palm, or the knee might lock in a bent angle.
And can you fix that?
Once a severe contracture sets in, it is often irreversible without surgery. It is incredibly painful, it makes hygiene nearly impossible, and it severely limits whatever quality of life the resident has left. That is why ROM exercises are a non-negotiable core responsibility for the CNA.
There is a specific concept tested regarding the CNA's exact role in passive ROM. The correct statement is that the CNA performs all movements while the resident remains entirely relaxed.
It is vital to understand the distinctions here. Let's define the terms. Passive ROM means the resident is entirely passive. They are doing zero physical work. The CNA is providing 100% of the physical effort to lift the limb, support the joint, and move it through its range.
How does that differ from active ROM?
Active ROM means the resident has the strength and ability to do the movement entirely on their own. The CNA might stand nearby to observe, instruct, or provide encouragement, but the resident's muscles are doing the work. And then there is active assisted, where the resident does what they can and the CNA helps them finish the movement.
Now, I have to play devil's advocate here, because if I'm a student, I'm looking at a wrong answer on this test that says, well, ROM exercises should only be performed by physical therapists. And honestly, that sounds correct to me. Moving joints around to prevent atrophy sounds like specialized physical therapy. Why is that wrong?
It is a very common trap. Physical therapists are the highly trained specialists who assess the patient, diagnose the deficits, and prescribe a very specific therapeutic exercise regimen to rehabilitate an injury.
Right.
But CNAs are the frontline workers. Performing basic, modified passive range of motion is considered a routine part of daily hygiene and maintenance care. It is meant to maintain the baseline joint function, not necessarily to rehabilitate an injury.
Oh, that makes a lot of sense.
Therefore, doing these basic movements under the supervision of a nurse and per the facility's care plan is absolutely within the CNA's scope of practice.
Which is exactly why the NNAAP tests you on it physically. They have two specific skills for this. Skill 15 covers the knee and ankle, and Skill 16 covers the shoulder.
And if you look closely at the rubrics for those skills, there are a few golden rules that apply to both. If you violate these rules, the examiner will fail you on the spot.
Let's break those down. What is the first golden rule of setup?
Ensure the resident is supine. Supine means lying completely flat on their back in the bed. You cannot properly or safely perform these specific standardized ROM test skills if they are sitting up in a chair or lying on their side. The mechanics of the joint movements require a flat, neutral spine.
The second golden rule is all about communication, specifically regarding pain.
This is critical. Before you start moving their limb, you must explicitly verbally instruct the resident to inform you if they feel any pain or discomfort during the exercise. You have to give them permission to stop you.
And what if they do? What if you bend their knee halfway and they wince and say, ouch, that hurts? Do you try to gently push past it just a little bit to get the stretch?
Absolutely not. You must immediately discontinue the exercise for that joint. You never, ever push through a resident's pain during passive ROM.
Wow, okay.
You are not a physical therapist trying to break up scar tissue. You are maintaining mobility. You move the joints gently, slowly, and smoothly. And the second you meet resistance or they verbalize pain, you stop, return the limb to a resting position, and report it to the nurse.
Stop immediately. Got it. And the third golden rule is the magic number. When you are doing these movements, how many times do you have to do each specific motion?
The standard for the exam is at least 3 times. The examiner will literally be standing there silently counting your repetitions. If you bend the knee twice and move on to the ankle, you fail the step. It must be at least 3 times for each specific movement, unless, of course, they report pain on the first or second rep.
Okay, let's do a vocab check, because the terminology in these skills can sound like a foreign language if you aren't used to it, and the examiner won't translate for you. Let's look at skill 15. It talks about flexion and extension of the knee. What am I actually doing with their leg?
Let's simplify it. Flexion means to bend. Think of a bodybuilder flexing their bicep. They are bending their elbow to make the muscle pop. So knee flexion simply means bending a knee.
Okay.
You are supporting their leg and bringing their heel up toward their buttocks. Extension's the opposite. It means extending or straightening it back out flat on the bed. Bending and straightening.
Okay, flexion is bend, extension is straight. Then we move down to the ankle, and the words get weirder. Dorsiflexion and plantar flexion. I see students panic over these two all the time.
It helps to break down the roots of the words. Dorsiflexion involves the dorsal surface of the foot, the top part. When you perform dorsiflexion, you are gently pushing the bottom of their foot so that their toes point up toward their head.
I always picture the dorsal fin of a dolphin. It's on the top of their back, pointing up out of the water. So dorsiflexion is pulling the toes up toward the body, toes to the nose.
That's a great visual. Now, plantar flexion involves the plantar surface, the sole of the foot. When you perform plantar flexion, you are gently pulling the top of the foot down, pointing the toes away from the body.
The easiest way to remember plantar flexion is to think about planting your foot on the gas pedal of a car. When you step on the gas, you point your toes down.
Exactly. Toes to the nose is dorsiflexion. Stepping on the gas is plantar flexion.
I love that. And then we move to skill 16 for the shoulder, which introduces 2 more tricky terms, abduction and adduction.
These describe moving the limbs sideways relative to the midline of the body. Abduction is moving the straightened arm laterally away from the side of the body, up to about shoulder level.
The mnemonic I use for this one is a little sci-fi, but it works. Think of the word abduction. If an alien abducts you, they take you away. So abduction is moving the arm away from the center of the body.
It sounds silly, but if it helps you remember it under pressure, use it. The opposite motion is adduction. You are bringing the arm back down to rest against the side of the body.
And adduction has the word add right in it. You're adding the arm back to the core of the body.
Perfect. Abduct is away, adduct is add it back. And the final critical piece of all these ROM skills is how you hold the limb. You never just grab the resident's hand and start cranking their arm around like a pump handle.
Where should my hands be?
You must provide support at the joints. When you are doing the knee, one hand supports under the knee and the other supports under the ankle. When you are doing the shoulder, one hand supports the elbow and the other supports the wrist. You are bearing the heavy weight of the limb so the joint itself doesn't undergo stress.
Okay, so we've mastered the bed. We can turn them, position them perfectly with gravity, and keep their joints from freezing up. But eventually, we have to get the resident out of the bed. And the moment that weight shifts from the mattress to the floor is when everything can go terribly wrong.
This is the danger zone. The vast majority of falls and staff injuries happen during transfers. We're looking specifically at skill 22. Transfers from bed to wheelchair using a transfer belt.
Let's walk through the physical setup. I call this the pre-flight checklist, because if you mess up the setup before the resident even moves, the transfer is doomed. Let's start with the wheelchair itself. Where does it go?
The wheelchair must be positioned alongside the bed. It can be placed at the head of the bed facing the foot, or at the foot of the bed facing the head.
So it's parallel to the bed. I've seen people try to place the wheelchair facing the bed perpendicularly like they're trying to drive it under the mattress.
If you place it facing the bed, the resident has to stand up, turn 180 degrees completely around, and back up into the chair. It requires too much balance and coordination. If it is parallel, they simply stand, pivot 90 degrees on one foot, and sit down. It is a much tighter, safer movement.
Okay, wheelchair is parallel. Next on the checklist, the footrests.
The footrests must be folded up and out of the way or removed completely if the chair allows it.
What happens if you forget and leave them down?
As the resident pivots, their feet will inevitably clip or step on those metal footrests. Two things will happen instantly. They will trip, and the weight of them stepping on the front of the footrest will cause the entire wheelchair to tip forward, pitching them onto the floor.
So footrests up. Now for the most critical part of the chair, the brakes. The practice test specifically asks at what exact point the nursing assistant should apply the wheelchair brakes.
The correct answer is before assisting the resident to stand.
It seems so obvious, right? Lock the brakes before they get up. But the wrong answers highlight some incredibly common real-world mistakes. One option suggests locking only on one wheel for easier transfers. Why is locking just one brake so dangerous?
Think about the physics of a wheelchair. If you lock the right wheel but leave the left wheel unlocked, what happens when the resident backs up and puts their weight against the front edge of the seat?
Oh, I see.
The chair doesn't stay still, it spins. The unlocked left side swings wildly backward in a circle, pivoting on the locked right wheel. The chair literally slips right out from underneath them and they fall to the floor. Both brakes must be locked tight.
Another wrong answer suggests that the resident should apply the brakes themselves to promote independence. I thought we were supposed to encourage independence.
We do encourage independence in activities of daily living, like brushing teeth or eating, but ensuring the mechanical safety of the environment prior to a high-risk physical transfer is the CNA's non-delegable clinical responsibility. You do not rely on a resident who might be weak, confused, or have poor grip strength to secure the equipment that is about to catch their entire body weight. You lock it, and you physically check it yourself.
Wheelchair is parallel, footrests up, both brakes locked. What about the bed?
You need to ensure the bed is at a safe level, which usually means the lowest position possible, so that when the resident sits on the edge, their feet are completely flat on the floor. Check that the bed wheels are locked as well.
Flat on the floor. If their legs are dangling like a kid on a tall stool, you cannot attempt the transfer. And crucially, they must have shoes on. Non-skid shoes or slippers must be securely on their feet before they ever bear weight.
Socks on a linoleum floor are like ice skates.
Okay, the environment is secure. Now we introduce the most important tool in mobility, the transfer belt, also known as a gait belt. Both Skill 3 and Skill 22 cover the application of this belt. It goes securely around their waist, but there's a major safety point tested here. It goes over their clothing or over a gown. Never ever on bare skin.
We talked about shearing forces earlier when rolling a patient in bed. The risk of skin shearing here is astronomical. A transfer belt is made of heavy, rough canvas webbing.
Yeah.
If you place that directly against the fragile, paper-thin skin of an elderly resident, and then you apply upward lifting force, that canvas will grind against the epidermis. It can literally tear the skin right off their waist. The clothing provides a necessary friction barrier.
The belt is on, snug, but not cutting off circulation. Now for the CNA stance. The handbook states you must stand facing the client, positioning yourself to ensure safety. Specifically, you must maintain the stability of the client's legs by standing knee to knee or toe to toe with them.
Cert Prep Academy actually has a whole section on transfer skills in their free study guides, and they emphasize that this knee-to-knee phrasing is exactly what graders are trained to look for explicitly.
Let's visualize that knee-to-knee stance. Let's break down the mechanics of why we do it.
When a resident with severe leg weakness or neurological deficits tries to push up from a bed, their quadriceps often fail. When the quads fail, the knees naturally buckle forward and fold under them. Their center of mass drops straight down.
So if I'm standing a foot away from them and their knees buckle, I'm just going to end up holding them up by the belt while they dangle there, destroying my back.
Exactly. But if you are standing knee to knee, meaning you have stepped in close, your feet are wide for a base of support, and the front of your knees are physically pressing against the front of their knees, specifically the tibial area just below the kneecap, you have created a physical wall.
They literally cannot buckle forward.
Right. Because your legs, powered by your strong quadriceps, are providing the structural support that their legs lack. You act as a fulcrum. As they lean forward to stand, their weight pushes against your knees, which stabilizes them and allows the upward momentum to continue safely.
It really is pure physics. You are becoming their temporary exoskeleton. So your legs are doing the blocking. What are your hands doing? The skill requires an upward grasp on both sides of the transfer belt.
Meaning your hands are in an upward position. You slide your fingers under the belt from the bottom edge, so your palms are facing up toward the ceiling.
Why is that better than grabbing it from the top down, like grabbing the handle of a suitcase?
Oh.
It feels more natural to grab from the top.
It might feel natural, but it is biomechanically weak. Think about how your hand works. If you grab the belt from the top down, your fingers are hooked under the bottom edge.
Okay.
If the resident suddenly collapses, the massive downward force of their weight will pull against your finger joints. Your fingers will be forced open, your grip will break, and they will fall.
But if you use an upward grasp,
If your palms are facing up and tucked under the belt, and the resident starts to fall, their downward weight actually pushes the canvas belt deeper into the meat of your palm and against the heel of your hand. Gravity tightens your grip instead of breaking it. Your arm bones are supporting the weight, not your delicate finger flexors.
that is brilliant. Gravity works for you, locking the grip in place. And finally, before you move, you need the count. You must provide a prearranged signal-like counting to 3 out loud, so the resident knows exactly when to begin standing.
Synchronization is safety. If you start pulling up before they are mentally ready to push, you are deadlifting dead weight and will strain your back. If they suddenly heave forward before you have braced your core, they might topple you over backward. 1, 2, 3, stand. Ensures you are both applying maximum effort at the exact same millisecond.
Okay, so we've successfully transferred them. They are out of bed, they're standing. The next challenge is getting from point A to point B, which brings us to ambulation and what I like to call the which side paradox.
Oh, the paradox. If there is one area that consistently confuses students and causes them to second-guess themselves on the exam, it is this. The rules for which side of the resident you should stand on seem to completely contradict each other depending on what equipment you are using.
I know, it drove me crazy when I first learned it. Let's start with the absolute basics. Skill 3, assists to ambulate, using transfer belt. Once they are standing, the textbook says you walk slightly behind into one side of the client for a distance of 10 feet while maintaining that upward grasp on the belt at their back.
Standing slightly behind and to the side is strategic. It gives you a mechanical advantage. If their knees buckle, you are in the perfect position to pull their center of mass backward toward you, widen your stance, and ease them down to slide along your leg to the floor rather than letting them face plant forward.
Okay, but which side do you stand on? This is where the paradox comes in. If you look at the practice materials, question 55 and question 28 basically ask the same thing but have opposite answers.
Yay.
Let's look at question 55. It asks, which of the following is the correct way to assist a resident with limited strength to walk using a gait belt?
And the correct answer is, place the gait belt snugly around the resident's waist, hold it from above, and stand on the resident's weaker side.
Stand on the weaker side. Got it. Now let's look at question 28. It sets up a similar scenario. When assisting a resident with ambulation who has weakness on one side, but you are without a belt, where do you stand?
The answer to question 28 is, stand on the strong side and allow the resident to use your arm for balance.
If you are listening to this and pulling your hair out because those rules seem completely opposite, you aren't alone. It feels like a trick question designed to make you fail. If I have a belt, I'm on the weak side. If I don't have a belt, I'm on the strong side. Why?
It is not a trick. It is entirely based on the laws of physics and leverage.
Yeah.
Let's break it down so you never have to memorize it. You just understand it. Scenario 1. You are using a gait belt. That belt gives you a firm mechanical grip directly on the resident's center of gravity, their waist.
Right.
Now, if a resident has a paralyzed or very weak left leg, which way are they most likely to fall when they walk?
They are going to collapse toward the left. The weak leg will buckle, and gravity will pull them down on that side.
Exactly. Because you are holding a strong canvas belt, you want to position yourself exactly where the collapse is going to happen. You stand on that weak left side. If they start to go down to the left, you are right there. You brace your core, pull up on the belt, and catch their weight. You act as a rigid brace for their weak side.
Okay, I can visualize that. Belt equals weak side, because I am ready to physically catch the collapse using the handle around their waist. So why on earth do I change to the strong side if there's no belt?
Because without a belt, you have absolutely no leverage on their center of gravity. Think about it. If you stand on their weak left side without a belt and they suddenly collapse to the left, how are you going to stop them?
I'd have to reach out and grab their arm or grab a handful of their hospital gown.
If you grab their arm while they're falling, you will easily dislocate their shoulder. If you grab their clothing, it will rip or it will just pull you off balance and you will both crash to the floor. You cannot safely catch a falling adult without a mechanical advantage.
Right, there is nothing to safely anchor onto.
So instead, when you don't have a belt, your role changes. You are no longer the safety net ready to catch them. You become a human handrail to prevent them from falling in the first place. You stand on their strong right side.
Because their strong hand can actually grip my arm.
Yes. You offer your forearm. They use their strong right hand to grip your arm tightly and lean on you for balance and support. They are using their intact strength to stabilize themselves against you.
That makes so much sense when you explain the mechanics. With a belt, you have the leverage to be a safety net on the weak side. Without a belt, you lack leverage, so you act as a handrail on the strong side.
Let's look at the wrong answers they give you for question 28, the no belt question, because they are very illuminating. One incorrect option says to let the resident walk independently to build their strength.
Which sounds like great physical therapy, but is a massive, immediate fall risk for a CNA to allow without an order and a belt.
Another incorrect option says to hold them tightly around the waist with your bare arms. Holding a resident tightly without a belt restricts their natural swinging movement, throws off their gait, strips them of their dignity and personal space, and frankly, if they fall, your bear hug won't stop them. It just guarantees you both hit the deck.
That distinction is so important. Belt equals weak side. No belt equals strong side. Now let's add an inanimate object to the mix. Canes. Question 6 asks, when assisting a resident to ambulate with a cane, which side should the cane be held on?
The cane must go on the unaffected or stronger side.
Again, this trips people up intuitively. If my left leg is weak and painful, shouldn't I put the cane in my left hand to help prop up that weak side?
Instinctively, we want to put the support right next to the injury. But biomechanically, that is a disaster. To understand why, you have to think about the natural rhythm of human walking, which is called a reciprocal gait. When you walk, your arms and legs swing in opposition to maintain balance. When your left leg steps forward, your right arm swings forward.
Right, nobody walks with their left arm and left leg swinging forward at the exact same time unless they are marching like a robot.
Exactly. So if your left leg is weak, we put the cane in your strong right hand. Because of that natural opposite swing, when your weak left leg steps forward, your strong right arm holding the cane comes forward at the exact same time.
Oh, wow. So the cane hits the ground at the exact same moment the weak leg hits the ground.
Yes. They strike the floor simultaneously. The strong arm pushes down on the cane, and it literally shares the weight-bearing load. The cane acts as a temporary third leg. It shifts the center of gravity away from the weak leg and distributes the pressure up through the strong arm.
And if you put the cane on the weak side, and the weak left hand.
You are asking a weak, possibly uncoordinated arm to fully support a weak, painful leg. It defeats the entire purpose of the device and drastically increases the fall risk.
That reciprocal gait explanation is the light bulb moment. The cane and the weak leg move together as a team. Since we are deep into the weeds on strong versus weak sides, we have to talk about dressing, because this rule is absolute on the exam and it is tested multiple times. Let's look at questions 11 and 42. They both address how to dress a resident who has one-sided weakness, like someone recovering from a stroke.
The fundamental, unbreakable rule of dressing on this exam is you dress the weak or affected side first, and when you are taking clothes off, you undress the strong side first.
I remember struggling to keep this straight, so I came up with an acronym. I used DEF, dress affected first, or, if that doesn't stick, think POW, put on weak.
Let's explore why POW makes sense mechanically. Why do we put the weak arm in first? Imagine you are a resident with a paralyzed left arm, and you are trying to put on a button-down shirt. Let's say you do it wrong, and you put your strong, fully mobile right arm into the right sleeve first.
Okay, so the right arm is in. The shirt is now bunched up around my right shoulder and pulled across my back.
Exactly. The fabric is stretched tight. Now you have to get your paralyzed, stiff left arm into the left sleeve. Because the shirt is already anchored on your right side, there's no slack. You or the CNA would have to physically grab your paralyzed left arm, bend it awkwardly backward behind your torso, and blindly try to thread it through a tight sleeve opening.
Which would be incredibly painful. You are forcing a joint that has no muscle control into an unnatural backward extension. You could easily dislocate their shoulder or tear a tendon.
But if we follow the rule, dress the affected first. If we take the totally loose, unanchored shirt and gently slide the left sleeve all the way up the weak, paralyzed left arm first.
It's easy. Because the shirt has all the slack in the world. I don't have to bend the weak arm at all. I just pull the fabric over it.
Precisely. Once the weak arm is safely in the sleeve, the resident can easily use their strong, fully functional right arm to reach behind them, grab the remaining fabric, and smoothly slide their good arm into the right sleeve.
It is all about utilizing the mobility they still have to compensate for what they've lost. You give the difficult task, the weak arm, the advantage of having a loose shirt. You give the easy task, the strong arm, the challenge of reaching for the tight sleeve. Dress the weak first. Undress the strong first.
Look at question 11 in your materials. It explicitly asks the sequence for putting on a shirt for a resident with right-sided weakness. The correct answer is to put the affected right arm through first, then the strong left arm. The wrong answer suggests doing the opposite or buttoning the front of the shirt before putting the arms through.
If you button the shirt first, it would basically become a straitjacket. You'd be trying to wrestle two arms into a closed tube.
Which is physically impossible and totally ignores the mechanics of dressing.
So much of this boils down to finding ways to maximize whatever independence the resident still has while keeping them completely safe, which actually provides a perfect transition to our final area of focus today. We've talked about moving their bodies. Now we need to talk about how they move through their environment.
Mobility isn't just about the physical act of walking 10 feet down a hallway for exercise. It is about how the resident navigates their daily world, how they dress, how they use the bathroom, how they bathe, despite profound physical limitations. The exam tests your clinical judgment in choosing the right adaptive equipment to maintain their independence.
Yeah, we see this theme come up a lot in the CERT Prep Academy practice tests. They give you a scenario where a resident is struggling, and you have to pick the tool that fixes the problem without doing the work for them. Let's look at question 7. A resident with severe arthritis is having difficulty putting on their shoes due to an inability to bend over. What adaptive equipment should the CNA suggest?
The correct answer encompasses long-handled shoe horns, elastic shoelaces, and slip-on shoes.
Let's break down the physiology of the problem first. Why is arthritis stopping them from putting on shoes?
Arthritis causes inflammation, severe joint pain, and stiffness. It heavily impacts the spine, the hips, and the fine motor joints in the fingers. For someone with advanced osteoarthritis in their spine and hips, bending over at the waist to reach their feet might be physically impossible due to the structural changes and the pain. Furthermore, the arthritis in their hands means they lack the dexterity and grip strength to tie intricate bows with shoelaces.
So how do the tools solve this?
A long-handled shoehorn acts as an extension of their arm. It extends their reach by 2 feet, allowing them to hook the heel of their shoe and guide their foot into it while remaining in a relatively upright, seated position. They don't have to bend their hips past 90 degrees. Elastic shoelaces turn any supportive lace-up sneaker into a slip-on shoe. They stretch to let the foot in, then snap back for a snug fit, completely eliminating the need for fine motor finger skills.
One of the wrong answers for that question suggests the CNA should just provide standing assistance while the resident puts the shoes on.
While standing assistance is helpful for balance, it does absolutely nothing to solve the underlying biomechanical problem. If their spine won't bend and their fingers won't tie, standing next to them won't magically make them able to reach their toes. It doesn't promote independence. It just delays the inevitable point where the CNA has to kneel down and do it for them.
Let's apply that exact same logic of environmental adaptation to toileting, which is a massive quality of life issue. Question 9 features a resident who is unable to use a regular bathroom toilet due to limited mobility and weakness. Which equipment helps maintain their independence?
The answer involves utilizing a raised toilet seat with grab bars and keeping a commode at the bedside for nighttime use.
Why a raised toilet seat? Toilets seem pretty standard.
A standard toilet is actually quite low to the ground. For a younger person, it's fine, but for an elderly resident with weak quadriceps, bad knees, or a recovering hip replacement, lowering their center of mass that far down, and more importantly, trying to push all that weight back up from a deep squat is incredibly difficult.
It requires a massive range of motion and a lot of explosive strength.
Exactly. A raised toilet seat adds several inches of height to the bowl. This drastically reduces the range of motion required. They only have to lower themselves a little bit, and they don't have to push up from a deep deficit. The addition of grab bars provides upper body leverage, allowing them to use their arm strength to assist their weak legs.
And the commode at the bedside solves a very specific nighttime danger.
Think about the environment at 2 a.m. The resident is groggy from sleep medications. The lights are low, their blood pressure might drop when they stand up. The distance from the bed to the bathroom might be 20 feet. That 20-foot walk is an absolute minefield for falls. Placing a portable commode right next to the bed eliminates the distance. They take one pivot step and they are safe.
Now, if we look closely at the wrong answers for question 9, they are frankly a little disturbing from a care perspective. One option suggests using adult incontinence products, meaning diapers, instead of providing toileting assistance.
That is a terrible, unfortunately common, and entirely inappropriate clinical decision.
Why? If they can't walk well, isn't it safer for them to just use a brief in bed?
If a person has limited mobility, but still possesses intact bowel and bladder control, meaning their brain knows they have to go and their sphincter muscles work, putting them in a diaper is a devastating blow to their psychology. It strips them of their dignity. It forces them to lie in their own waste. Physiologically, urine and feces are highly acidic. Being trapped against the skin in a warm, moist diaper rapidly causes skin maceration and severe pressure ulcers. You are introducing a massive infection risk simply because the facility failed to provide the proper mechanical equipment to help them sit on a toilet.
Wow, so choosing a diaper for a continent person just for staff convenience is essentially medical negligence.
In the eyes of the state examiners, yes. Another wrong answer suggests restricting the residents' fluids so they don't have to eliminate as often.
Which would cause severe dehydration, urinary tract infections, and eventually kidney failure. You never, ever restrict life-sustaining fluids just to make toileting easier on the staff.
You always adapt the environment to the patient, never force the patient to suffer for the environment. But we must balance this independence with safety. Look at question 20, which is regarding the use of that bedside commode we just talked about. The most important safety measure is to ensure the grab bars are within reach and that the CNA stays nearby to provide support if needed.
One of the wrong answers suggests leaving the resident completely alone in the room to provide maximum privacy during elimination.
Privacy is a fundamental resident right guaranteed by federal law, but it does not override imminent safety. If a resident is using a bedside commode, they are by definition a documented fall risk with severe mobility limitations. You cannot abandon them.
How do you balance that? How do you give privacy while staying nearby?
You provide privacy by pulling the privacy curtain around the commode, but you stand right on the other side of that curtain. Or you stand near the doorway of the room, keeping an ear out, constantly monitoring. You give them auditory privacy and visual privacy, but you do not leave the physical space. If they try to stand up on their own and start to fall, you have to be within a few seconds of reaching them.
Yeah, I feel like we see this theme come up a lot in the Cert Prep Academy practice tests. You are always looking for the one option that maximizes a resident's independence and dignity, but firmly maintains a safety net. You never sacrifice one for the other.
A prime example of balancing that dignity with safety is showering. Question 14 asks for the primary reason for placing a shower chair or bench in the shower stall for a resident.
And the primary reason the exam is looking for is to provide safety, reduce fall risk, and conserve energy for weak or elderly residents.
Let's bring back the physiology we discussed earlier regarding the dizzy resident. A hot shower causes vasodilation. Blood vessels expand, blood pressure drops. Furthermore, standing requires constant, subtle muscle contractions in the core and legs to maintain balance. For a frail 85-year-old resident, standing upright in a slippery, hot, steamy environment for 10 straight minutes is the equivalent of running a marathon. It is exhausting.
Their muscles fatigue, their blood pressure drops, and they collapse.
By placing a shower chair in the stall, you instantly neutralize the energy drain. The chair supports their body weight. It conserves their vital energy so they can actually focus on the task of washing their own arms and torso, maintaining their dignity and independence while completely eliminating the fear and risk of falling.
The wrong answers on this one are so revealing about the wrong mindset. One option says the chair is there to make it easier for the CNA to reach all areas of the resident's body without bending over.
While a shower chair might happen to be a convenient side effect for the CNA's back, the medical equipment is not there for staff comfort. It is purely a clinical safety intervention designed for the resident's physiological needs.
It's all about them. Everything we've talked about today, the physics of lifting, the angles of the bed for digestion, the sides you stand on with a gait belt, it all revolves around creating an invisible biomechanical bubble of safety around the resident, while letting them do as much as they possibly can.
That is the beautiful essence of physical care. When their body fails, your knowledge of physics and anatomy steps in. You become a literal extension of their physical capabilities.
Okay, we have covered an absolute massive amount of ground today. If you're taking the NNAAP written exam soon, this deep dive is pure gold. Let's bring it all together. I'm going to do a rapid-fire, 1-minute recap of the absolute essentials you must remember from today.
Go for it.
Number 1, body mechanics. When lifting, bend at the knees, not the waist. Keep your back straight to protect those discs and use your glutes and quads. Number 2, turning a resident. Always lower the head of the bed flat first to prevent skin shearing, and always raise the side rail on the side they are turning toward so they don't fall. Number 3, range of motion. Passive ROM means the CNA does all the physical work, but if the resident expresses any pain, you stop immediately. And remember the magic number, at least 3 times per joint. Number 4, wheelchair transfers. Lock both brakes before they stand up so the chair doesn't spin, and block their weak knees from buckling by standing solidly knee to knee. Number 5, gait belts go over clothing, never bare skin, and you must use an upward grasp so gravity tightens your grip. Number 6, the paradox. If using a gait belt, stand on the weak side to catch them. If walking without a belt, stand on the strong side to be a handrail. Canes always go on the strong side. And finally, number 7, dressing, DAF or PRW. Dress the affected or weak side first to avoid painfully twisting paralyzed arms.
Excellent summary. Every single one of those points represents a specific, highly testable concept on the NNAAP written exam. They're practically guaranteed to show up.
And listening to us explain the concept is one thing, but practicing it until it becomes second nature is how you actually pass the test on exam day.
Exactly. If you want to test yourself on these exact scenarios we've been discussing, you need to head over to certprepacademy.com.
For sure. The best part is certprepacademy.com is completely free. There's literally no sign-up required to get started. You just click and go. They have a massive 70-question practice test that identically mirrors the format and difficulty of the real NNAAP exam. They also have free, detailed study guides covering every single topic on the test and digital flashcards to help lock in all these weird medical terms like dorsiflexion, ischemia, and Fowler's position. Everything you need to pass is in one place, and it costs you nothing.
I highly recommend the flashcards for the positioning terms. Head over to certprepacademy.com right now. The link is right down in the description. Go check it out and run through a few scenarios.
And make sure you come back for episode 3 of our series, where we are going to dive into the second half of basic nursing skills. We'll be tackling infection control and emergency procedures. We're transitioning from the physics of mechanics to the invisible world of microbiology.
I'm really looking forward to it. Infection control is a whole different beast. But before we sign off today, I want to leave you with a final provocative thought to tie everything back to where we started. Next time you stand up from a chair today or get out of bed tomorrow morning, I want you to pause for a second. Pay close attention to exactly what your feet, your knees, and your core muscles are doing.
Yeah, try to actually feel the mechanics firing.
We do it completely automatically. You shift your center of gravity forward, you plant your feet flat, you engage your quadriceps, and you find your vertical balance without a single second thought. But when you really break it down biomechanically, it is a complex, almost miraculous chain of physical events. As a CNA, you are stepping into a world where illness, age, or injury has broken that chain for your residents. They can no longer do it automatically. Your knowledge and your physical presence become the missing link in that chain. You become their balance, you become their leverage, and you become their strength.
That is a powerful way to look at the job. It's not just moving people, it's restoring what they've lost. Keep studying, trust your mechanics, and we'll see you in episode 3.